So, imagine going to the doctor for chronic, agonizing joint pain. Like, you can barely walk, your knees are just absolutely on fire, and you're desperate for a solution.
Right, you just want the pain to stop.
Exactly. But instead of looking at the fact that you are, trying to run marathons in high heels, the doctor just hands you a bottle of painkillers and sends you on your way.
Which is wild because you're treating the symptom, but the underlying mechanical catastrophe is just continuing every single day.
Right. And today we are looking at a stack of medical guidelines, psychosexual therapy, literature, and physiological research that reveals millions of people are doing the exact equivalent of this in their bedrooms.
Yeah, it's a massive blind spot, and I'm thrilled we're digging into this.
Welcome to today's deep dive, everyone. Our mission today is to answer a highly specific, honestly mind-blowing question found deep within these sources. And that is, can an acute mismatch in sexual desire levels within a couple actually manifest clinically as a complaint of situational, unmanaged vaginal dryness?
It is a question that completely bridges the gap between, like, the couples therapist's couch and the gynecologist's exam table.
Yeah, it really forces those two worlds to collide.
It does, and finding the answer challenges almost everything mainstream culture teaches us about how human arousal actually works. It forces us to look at the body as an integrated system, rather than just a series of isolated parts.
Absolutely. And whether you, the listener, are researching this to navigate your own relationship dynamics or you're insanely curious about the intricate mind-body connection, this deep dive is going to completely change how you view physical symptoms.
I really think it will. The literature we're pulling from today is just incredibly eye-opening.
Okay, let's unpack this. We are taught that physical arousal is a simple cause and effect switch. You see something attractive, you feel desire, and boom, the body mechanically responds.
Right, like flipping a light switch.
Yeah, exactly. But the research reveals a much more complex reality where our emotional ecosystems directly dictate our cellular responses.
Which is where we have to start, because before we even get to the relationship mismatch part, we have to tear down the mythology surrounding the biology of what we colloquially call getting wet.
Because to understand the dysfunction, we first have to understand the function, right?
Precisely. The reality of vaginal lubrication is vastly different from the narratives we have all internalized. I mean, mainstream media suggests that lubrication is a direct, foolproof indicator of whether someone is turned on and ready to go.
Like it's a lie detector for desire.
Exactly. But physiologically, it is a highly specific, very delicate neurovascular event. It's a process called transudation.
Transudation, that sounds like, I don't know, something from an advanced fluid dynamics class.
It really does. But let's break down what is actually happening at a cellular level, because it's not just a gland turning on like a faucet.
Right, because there isn't actually a localized pool of fluid just waiting to be released, is there?
Not at all. When a person with a vagina experiences physical arousal, the parasympathetic nervous system, which is the body's rest and relax system, sends signals to the pelvic region.
Okay, the rest and relax system, that's key.
It is. This triggers the release of a molecule called nitric oxide. And nitric oxide acts as a chemical messenger telling the blood vessels in the genital area to rapidly dilate and engorge with blood.
So the blood vessels are swelling up.
Right. And as that localized blood flow dramatically increases, the physical pressure inside those vessels builds. This pressure literally pushes blood plasma through the vaginal walls.
Wow.
Yeah, the fluid filters through the epithelial cells to form a slippery, protective film on the surface of the vagina.
So it's basically a localized, pressure-driven filtration system relying entirely on vascular expansion,
Exactly.
which means the body has to be in a physiological state that allows blood vessels to relax and open up in the first place.
What's fascinating here is that lubrication is an entirely unconscious biological process. You cannot will your body to undergo transudation any more than you can will your face to blush or your armpits to sweat.
It's totally out of your conscious control.
It happens or it doesn't based on an incredibly complex interplay of nerves, hormones, and blood flow. And the sources point to a vital clinical concept called arousal nonconcordance.
I saw that in the reading. It's such an important concept.
It really is. It's the well-documented phenomenon where subjective arousal, meaning having mental desire and wanting to be intimate, and physiological arousal, the actual swelling and transudation, frequently do not match up.
One of the researchers phrased it perfectly. They said, the vagina is a complex organ, not a super soaker.
I love that quote. It is just so accurate.
Which completely flies in the face of the cultural narrative that says dryness automatically equals a lack of attraction, or worse, a lack of love. It's like trying to fall asleep when you're incredibly stressed out.
Oh, that's a great analogy.
Right. Because you can want to sleep more than anything in the world. You can be exhausted. You can lie there in the dark, actively demanding your brain to shut off. But if your body is tense and your nervous system is agitated, it simply won't happen.
No, it won't.
Sleep is not a conscious choice. You can only set the environmental conditions for it.
And you are relying on the exact same nervous system shift to fall asleep as you are to become physically aroused. They both require that parasympathetic nervous system to take the wheel. If the conditions aren't right, the system refuses to engage.
Which brings us to the core mystery of the sources. If this is an unconscious biological process that requires the rest and relax system to function, how does a partner's differing desire level actually reach in and flick that neurological switch off?
That's the million-dollar question.
Right. Like, how does a relationship dynamic literally stop blood plasma from pushing through a cell wall?
To answer that, we have to move from the pelvis up into the brain, which is undeniably the primary sex organ.
Okay, so we're looking at the neurological level now.
Yes. When a couple has mismatched libidos, meaning one partner consistently wants sex more often than the other, it creates this ambient dynamic of relational stress.
Because there's always that underlying tension in the house.
Exactly. For the partner with the lower desire, this often translates into feeling pressured, feeling anxious, or feeling a heavy sense of obligation just by walking into the bedroom.
It makes sense if you think about it from an evolutionary standpoint. I mean, if the brain senses a threat or extreme pressure, it's going to divert blood to the legs to run, not to the pelvis to reproduce, right? The body is prioritizing survival over intimacy.
If we connect this to the bigger picture, your evolutionary analogy is spot on. The brain is highly attuned to expectations and pressure.
So it's constantly scanning the environment.
Yes, and when the lower desire partner senses that constant ticking clock of expectation, their brain doesn't interpret it as, oh, my partner loves me and wants to be close.
How does it interpret it?
It interprets the pressure as a threat. And the moment the brain perceives a threat, it slams the brakes on the parasympathetic system and activates the sympathetic nervous system. That's the fight-or-flight response.
The exact opposite of the state required for transudation.
Completely. The sympathetic nervous system is designed to keep you alive in an emergency. It pumps you full of adrenaline and cortisol and pulls resources away from non-essential functions.
Like digestion and reproduction.
Right. And when this system activates, it directly inhibits the release of nitric oxide in the pelvic region.
Oh, wow. So without nitric oxide, the blood vessels stay constricted.
Yes, the blood flow halts. And without that vascular pressure, transudation completely stops.
The literature really hammers this home with the SWAN study. That's the study of women's health across the nation.
Such a landmark piece of research.
It really is. They tracked thousands of women over several years and isolated various factors affecting sexual health. And the researchers found something incredible. Anxiety is an independent risk factor for vaginal dryness, regardless of a woman's estrogen levels.
Which is a huge paradigm shift for how we treat this.
Exactly. Even if she is hormonally perfectly primed for arousal, the psychological anxiety itself overrides the hormones and shuts down the moisture. Does this mean the body is basically staging a physiological protest against the mismatched desire, even if the person's mind is trying to be willing and accommodate their partner?
Yes, absolutely. The body always prioritizes physical and emotional safety over sex.
Always.
If a mismatch in desire creates a lack of emotional safety or a lack of connection or just a constant hum of relational anxiety, the body limits arousal fluid to protect itself. It assesses the environment and concludes this is not a safe place to be vulnerable.
So the person's cognitive mind might be thinking, I love them, I want to connect, I should just do this to make them happy and keep the peace, but their nervous system is screaming, no, we are under threat.
That is the exact conflict. The cognitive mind is constantly trying to override the nervous system, but the nervous system always wins the physiological battle.
It's undefeated.
Right. The brain says yes out of guilt or love, but the tissue firmly says no. And this invisible disconnect is where the psychological and relational issue begins to morph into a very real, very painful clinical problem.
Which is where we see the physical consequences. Because so often the response to this dynamic isn't to stop, have a conversation, and address the pressure.
Unfortunately, no. Usually people just try to push through it.
Right. Out of that sense of duty to satisfy the partner with the higher drive, the person engages in penetrative sex without adequate arousal fluid.
And that is incredibly damaging. The vaginal tissue is incredibly delicate. When you introduce the friction of penetrative sex without the protective slick layer of transudation, you cause acute physical trauma to the tissue.
The medical literature documents this as microtraumas, right? Like tiny tears to the delicate opening of the vagina and the surrounding tissue near the bladder.
Yes, and microtears in some of the most sensitive tissue in the human body is just agonizing.
It sounds agonizing, and it goes way beyond just a few minutes of discomfort. The sources note that this friction and tissue damage changes the local pH and disrupts the healthy bacterial flora.
Which causes a cascade of other issues.
Exactly. It can precipitate recurrent urinary tract infections or UTIs and chronic vaginitis.
Clinically, this leads to dyspareunia, which is the medical term for painful intercourse. But look at it from the nervous system's perspective.
Okay, let's play that out.
The brain initially sensed a relational threat, so it shut down lubrication. The person pushed through and had sex anyway, resulting in physical pain. That physical pain validates the brain's initial threat assessment.
Oh man, so the brain is like, see, I told you the situation was dangerous. Next time, I'm going to protect you even more.
Exactly. So the next time their partner initiates, the ambient anxiety is massively amplified.
It's a self-reinforcing vicious cycle.
It is. The body reacts even more strongly to the heightened anxiety. Not only does it shut down the lubrication again, but it frequently triggers an involuntary defensive tightening of the pelvic floor muscles to protect against the anticipated pain.
And this condition is called vaginismus, right?
Yes. Now, you have a dry vagina and tighten, spasming pelvic floor muscles. This makes the next attempt at penetration even more painful, causing deeper trauma, more UTIs, and cementing an immense wall of anxiety.
Here's where it gets really interesting, because when this patient finally reaches a breaking point and ends up in a doctor's office, they aren't saying, hey doc, my partner and I have mismatched desire and the relational pressure is creating a fight or flight response.
No, because they usually don't even realize that's what's happening.
Right. They are presenting with a purely physical complaint. They say, I have situational, unmanaged vaginal dryness. I have severe pain during intimacy. I have chronic UTIs.
And the medical system often just takes that at face value.
Exactly. And often they get diagnosed with female sexual interest arousal disorder, FSIAD, or genital pelvic pain penetration disorder, GPPPD. Basically, a doctor stamping their chart saying their libido is broken or they just have a mysterious pain disorder.
This raises an important question about how modern medicine approaches sexual health. It highlights why comprehensive medical assessments cannot just be a quick check of estrogen levels, a prescription for antibiotics, or a localized pain cream.
It's back to the runner taking painkillers for a structurally terrible stride.
Exactly. A true assessment must dig into the patient's emotional ecosystem. Practitioners have to ask deeply personal questions about relationship satisfaction, partner conflict, and communication.
Because if you don't uncover the acute desire mismatch driving the anxiety, you are only treating the smoke and ignoring the fire.
100%. So if the root is relational, but the damage is physical, how do we successfully intervene? We have a patient who is trapped in a pain anxiety loop, suffering from microtraumas, all stemming from a dynamic in their living room.
The clinical consensus seems to be that we have to attack the vicious cycle from both ends simultaneously. We have to address the physical reality of the damaged tissue, and we have to overhaul the psychological and relational environment.
Let's start with the physical fix. Obviously, stopping the tissue damage is step one.
And the literature heavily distinguishes between lubricants and vaginal moisturizers, which operate on completely different mechanisms.
Right. Lubricants, which are typically water or silicone-based, are designed to be used right before sexual activity. They sit on the surface of the tissue to artificially mimic transudation and reduce friction temporarily.
So they are the immediate localized defense against microtears.
Yes. Vaginal moisturizers, on the other hand, are designed to be absorbed into the cellular structure of the tissue itself. They are used every few days, entirely separate from sexual activity, to improve the overall hydration, elasticity, and health of the vaginal wall.
They essentially help heal the localized trauma over time and restore a healthy physiological baseline.
Exactly.
Wait, I have to push back on this physical fix for a second, though.
Okay, go for it.
If the root cause is a relationship mismatch that's triggering a profound threat response, isn't using a lubricant just putting a Band-Aid on a bullet wound?
That's a really common critique, actually.
Right. Doesn't handing someone a bottle of silicone just enable them to keep ignoring their body's boundaries and having obligatory disconnected sex? Like, oh, my body is screaming no, let me just add synthetic moisture and do it anyway.
That is a very valid concern, and it is exactly why the physical fix alone is a failure of care. The physical tools are a prerequisite, not the cure.
Okay, a prerequisite. Walk me through that.
Think of the pain-anxiety loop. The physical pain of friction is the concrete evidence that reinforces the brain's threat response. By using a high-quality lubricant and moisturizer, you eliminate the physical trauma. You stop the bleeding, literally and metaphorically.
So you're taking away the brain's proof that sex is dangerous.
Yes, this breaks the immediate cycle of negative physical reinforcement, creating a neutral baseline. You cannot ask a highly agitated nervous system to calm down and do the deep psychological work, while the physical body is actively anticipating or experiencing acute pain.
Ah, okay. So the lubricant buys the couple physical safety, but the brain is still holding on to the memory of pain, still waiting for the other shoe to drop, still perceiving the partner's desire as a threat.
Exactly.
So how do you convince a panicked nervous system that it's actually safe in the present moment?
This is where the psychological interventions become crucial, specifically the research of Dr. Lori Brotto. Her work demonstrates that mindfulness and cognitive behavioral therapy, or CBT, significantly improve sexual health for patients dealing with these exact dysfunctions.
I read about that. It's like hitting the clutch in a manual car. The engine of your anxiety might still be revving high, but by focusing entirely on the physical sensations of the present moment, mindfulness disconnects the engine from the wheels.
That is a brilliant way to conceptualize it.
Thanks. So the threat response doesn't drive your physical reaction anymore.
Exactly. CBT and mindfulness train the brain to anchor in the present physical reality rather than spiraling into future-oriented anxiety.
Like, what if this hurts like last time? What if they get mad if I stop?
All those what-ifs.
Yeah.
By practicing mindfulness exercises like focusing intently on the temperature of the room, the texture of the sheets, or the rhythm of breathing, the patient actively quiets the sympathetic nervous system.
They dial down the fight or flight response.
Yes, and when the sympathetic system quiets down, the parasympathetic system can finally turn back on, creating the biological space for natural transudation and arousal to occur.
You are teaching the brain to say, we are safe right now in this exact second.
Exactly.
Okay, so we've protected the tissue with moisturizers, we've disconnected the anxiety engine with mindfulness, but we still have the elephant in the room.
The mismatched libidos.
Right. The lower desire partner might not be in pain anymore, but they still don't want sex as often as their partner. How do we fix the relational root?
We looked at the Gottman method, which is one of the most rigorously tested frameworks in couples therapy. And their approach to mismatched desire is incredibly counterintuitive.
Okay.
They argue that you don't fix it.
Wait, you don't fix it. You just accept that one person is always frustrated and the other is always pressured.
No, you shift the entire paradigm of the conflict. Gottman's research found that about 69% of relationship conflicts are perpetual problems.
69%, that's huge.
It is. And that means they are rooted in fundamental, unalterable differences in personality or lifestyle needs. A mismatch in baseline sexual desire is almost always a perpetual, unsolvable problem.
So couples must stop treating mismatched libidos as a solvable problem where one person just needs to compromise or change.
Right. Instead of trying to fix the lower drive partner's libido or tame the higher drive partner's appetite, you approach it as an ongoing dynamic that must be managed through profound mutual understanding.
The sources highlight a specific Gottman tool called the Dreams Within Conflict exercise.
Yes. The goal of this exercise isn't to negotiate how many times a week you have intimacy. The goal is to uncover the underlying meaning, the deeper emotional need hiding behind each partner's position.
How does that actually work in practice?
In this exercise, partners take turns. One person is the speaker, sharing their feelings without any fear of rebuttal, and the other is solely a listener, tasked entirely with understanding, not persuading.
Okay, let's picture how this actually plays out. During this conversation, the higher drive partner might realize and articulate that they aren't actually craving physical friction, they are craving reassurance.
Exactly.
Like, sex might be their primary way of feeling loved, feeling desired, or feeling securely attached to the person they value most. So if they are turned down, it doesn't feel like a physical rejection to them. It feels like emotional abandonment.
That is so often the case. And conversely, the lower drive partner has the space to articulate their reality. Their reluctance usually isn't a rejection of their partner at all.
It could stem from a deep need for bodily autonomy, right? Or just a need for rest in an otherwise exhausting life.
Yes, or a need for emotional connection that doesn't immediately escalate to physical demands. They might realize they don't hate intimacy, They just hate feeling like they owe a constant physical debt.
Wow. When a couple sits down and has that conversation, when they stop arguing about the frequency of sex and start validating the underlying dreams and fears driving the conflict, the entire atmosphere changes.
The pressure deflates.
The threat level in the room just drops.
And the biological irony is beautiful. When the lower drive partner feels truly understood, validated, and no longer pressured to change their fundamental nature, their nervous system registers safety.
The ambient anxiety dissipates.
Yes, and that psychological safety is the absolute prerequisite for their body to engage the parasympathetic nervous system and allow physical arousal to happen again.
It all comes full circle, from the couple's therapist's couch right back to the cellular level. The mind feels safe, the parasympathetic nervous system engages, nitric oxide is released, the blood vessels dilate, and the body physically responds.
It is a profound example of how our bodies carry our relational realities.
Right.
You cannot separate the physical tissue from the emotional environment it lives in.
We have traced an incredible, fascinating journey today. We've seen how a simple relationship mismatch in desire can cascade into an ambient nervous system threat response, how that chronic threat halts the biological process of transudation, and how that shutdown leads to a brutal cycle of microtrauma, pain, and pelvic floor tension that perfectly masquerades as a purely medical issue of vaginal dryness.
It really is incredible when you lay it all out like that.
So what does this all mean? It means that if you are experiencing this, reframing the question is the first step toward true well-being. We have to stop asking, how do I force my body to function, or what pill can fix my libido, and start asking, what does my body need to feel safe?
I couldn't agree more. It's moving from a mindset of fixing a broken machine to tending to a highly sensitive, deeply intelligent ecosystem.
I want to leave you, our listener, with a final thought to mull over long after this deep dive ends. We spend so much time culturally treating our bodies as objects to be managed, viewing their physical limitations, like vaginal dryness, as mechanical failures or shameful dysfunctions.
Right, as if the body is doing something wrong.
Exactly. But what if we flip that entirely? What if, instead, we viewed these physical responses as highly intelligent boundary setters? If a dry vagina is essentially the body's uncompromising lie detector test for emotional safety and relational alignment, perhaps it isn't failing you at all.
That's a really powerful perspective.
Perhaps it's fiercely protecting you. And if that's true, maybe the most profound medical intervention isn't a pill or a cream or a forced compromise, but simply radical honesty with ourselves.